All right, it's so great to see so many of you in the room, and I know we have lots of folks joining online as well. Welcome to a special session of the Research Ethics and Policy Series, which today is co-sponsored by the Cancer Control Program of the Abramson Cancer Center. My name is Holly Fernandez Lynch, and I co-chair the REP series with Steve Joffe. And today it is my pleasure to welcome alongside Dr. Joffe and Dr. Glantz, who co-lead the Cancer Control Program, to welcome Dr. Consuelo Wilkins, who's going to give a lecture today titled Engaging Communities in Research to Improve Science and Optimize Health. I'll say a few words of introduction in just a minute, but we have our usual kind of housekeeping announcements. So next month on May 13th, we're going to be joined by Allison Bennett, who's chair of the psychology department at the University of Wisconsin-Madison. And she's going to be presenting on the ethical imperative to conduct animal research. And you can find the full list of our upcoming speakers online, also on the screen here. And then a quick reminder about some of the online education resources from our department. We have a series of short research ethics courses available for free continuing education credit, some of which can also be used to satisfy research ethics training requirements at Penn and CHOP. We have recently updated the research ethics, the one with the asterisks there. So it's fully up to date for 2025. And if anybody has tried to use this previously, it was a little bit cumbersome. You had to print off a certificate and give it to the IRB. It should now be fully integrated in Workday. So that hopefully is another reason to pursue this training. And then just a quick thank you to our usual REPS co-sponsors who are shown here. And thank you to REPS coordinator Lisa Bailey for organizing this. All right, and with that, I am pleased to introduce today's speaker, Dr. Consuelo Wilkins. Dr. Wilkins is a nationally recognized physician scientist leader in health equity research, focused on integrating social, cultural, and environmental factors in clinical and translational research, and pioneering new approaches to engaging marginalized and socioeconomically disadvantaged populations in clinical research. She's professor of medicine in the Division of Geriatric Medicine at Vanderbilt University Medical Center, where she's also senior vice president and senior associate dean for community health and engagement. Dr. Wilkins is an elected member of the National Academy of Medicine and the American Society of Clinical Investigation. She's PI of 3 NIH-funded centers, the Vanderbilt Miami Meharry Southeast Collaborative for Chronic Disease Equity, which focuses on decreasing disparities among African Americans and Latinos, the Vanderbilt Recruitment Innovation Center, a national center dedicated to enhancing recruitment and retention in clinical trials, and the Vanderbilt Institute for Clinical and Translational Research. Her team, the Wilkins Health Equity and Engagement Lab, or WHEEL, great acronym, has developed new methods and tools intended to catalyze health equity research broadly, including instruments to assess trust and trustworthiness and a measure of person-centeredness of research. So while Dr. Wilkins's health equity and engagement research is relevant across clinical domains, it's especially relevant in the context of cancer. I know we have some folks from the Abramson Cancer Center here. So obviously it's no news to you that substantial racial and ethnic disparities persist in incidence and mortality rates and in cancer clinical trial participation. So we're especially grateful to have the Cancer Control Program co-sponsoring today's lecture and Dr. Wilkins's visit. Just a quick word about how we'll handle questions and discussion. When the lecture concludes, we have a lot of people in the room here today. I'll come to you first for questions. There's also the opportunity for those of you who are on Zoom to ask questions. You can feel free to post them in the chat and I'll read them, or you can raise your hand and I can call on as many people as we can get to today. All right, and with that, the floor is yours.
Thank you so much, Holly, for the kind introduction, which I tried to get her to shorten it a little bit to give you more time for questions. It's lovely to be here and meet so many amazing people and to see some great friends. And thanks again for the invitation. Steve invited me or talked about invited me some time ago, and we finally got around to making this happen. And delighted to be here today and share with you some of the work that we've been doing. As I was pulling together slides for today, and also this morning with some of the meetings, I realized that I'm probably not going to talk about everything that you all want me to talk about today. But I'm happy to answer questions about things that I don't get to talk about. I also, want to acknowledge the current environment and climate in which the work in which I'm talking about is existing, including the fact that some of the words and terms and language that's being used here is no longer a priority for some. Can we switch? Did I do that? I may have been. Yeah, this is fine.
Okay.
This is fine. In terms of the work and you heard about some of the work that's funded here. These are other funding sources for me. But newer this year, in the last few months, I've started to add a slide that says that what I'm going to talk about are my views and not reflecting the institution or funders. And so again, that's just for the record, in case that was not clear. So when I organized this, again, I thought about, what we should be talking about, and recognizing that there are a number of you in the room who have expertise in community engagement and community engaged research. And so some of this may seem, superficial or foundational level to you. So I'll try to get through that quickly, but if I speed past anything, feel free to stop me. So talk about what is engagement, some strategies for engagement, and give some examples of how my team has done some of this, and then end talking about trust and trustworthiness, and some of that work with Dr. Griffith, who's here. But in case I don't get through all of the slides, I'll just make quick points about the 4 things here. So why should you engage people? Because it makes your science better. What are the strategies to do meaningfully engage people? There are many strategies. You need to choose strategies that work for you and your community. And recognize, I was talking with Dr. Glanz's group earlier, the most important, the best strategies often depend on you having a team of people who have the right characteristics to actually do engagement. And that means you need to be trustworthy, have humility, and be willing to learn. Some of the work that I'm going to talk about, again, we could give, a lot of different examples of what works, and how to do engagement. In order to do engagement well, you need to have measures of success. And for me, the most important measure of success is that something changed after you did the engagement. If nothing changed, if your priorities didn't change, if the study design, the way you do recruitment, the protocol, the person-centered, outcome measures, if the way you do the analysis and dissemination, if nothing changed, you did not do engagement. Maybe you had lunch, maybe you had tea, pizza, maybe you had a cab come and you did a dog and pony show, but that doesn't count as engagement if nothing changed. And then the last piece there about trust and trustworthiness is, for a long time, we have talked about communities needing to trust us and that we need to build trust. And recently, we've shifted that to being trustworthy. So what have you done? What are you doing as individuals, as organizations, as groups to demonstrate that you are worthy of them trusting you? Because there is a power imbalance in terms of trusting. And if you want people to trust, then you need to look inward to determine if you are actually worthy of that trust. Okay, so my title is saying that, we need to do this engagement to improve science, improve health outcomes. And that presumes that you believe that things need to be improved. Maybe you think that everything's perfect, that, we're doing well, that we're not, spending 20% of our GDP on healthcare, and that, everybody's, enjoying optimal health. And the truth is that's not the case. Even though we've had many advances in science and medicine, those advances have not benefited everyone the same. And so I'm sharing with you, and there are many examples of this, I'm sharing with you from the National Academy of Medicine report last year, which I had the honor of being one of the committee members on ending unequal treatment. And it was really a look back at the unequal treatment report that came out in 20 years before. And so the National Institutes of Health and a couple of other agencies were interested in what progress have we made in the last 20 years. The report specifically talks about racial and ethnic disparities, and builds on some other work that had been done. But really at the time, the focus was on, we're seeing still these striking disparities in health outcomes among marginalized and minoritized racial and ethnic groups. And so we looked back at the last 20 years and some of the things that happened, and some of the progress. And the bad news is that we have not done well. So we have made very little progress actually in decreasing health disparities. There are a few areas where we might have seen some narrowing of the gaps, but for the most part, we've not done a great job. I will say that in terms of research and the research enterprise, up until recently, we had seen, and I talked about this some this morning with both Scott and Robbie about some of the changes in NIH funding priorities, and how the current priorities could have devastating impacts on what we're now no longer going to prioritize in some of the infrastructure that we built in. This work takes decades for us to see progress. And so a lot of what we're at risk or likely to lose, we don't even know yet, because we're just starting to potentially see some of the benefits of those changes that we've made in the last couple of decades. So we should all be concerned about what we're likely to lose. And I think in terms of what we should be doing differently, the last point here is one that I'd like to emphasize, is that we've been in this space of almost seeming as if the work that we're talking about in reducing disparities and inequities is at odds with the broader work. And this sense that it's a zero-sum game if everybody is healthy. And again, I think this is one of those areas where we've not clearly communicated why this work is important to everybody, how making sure that everybody is healthy decreases overall costs, the opportunities for us to be thriving in our communities and have better education, less waste, more wealth, like all of these things are tied together. But somehow we continue to marginalize some and think that doesn't impact everyone. As the committee, and for those of you who have been on National Academies committees or any committees like this, lots of discussions around things, including like what the conceptual framework looks like. Aaron is laughing, yes. The many iterations of the conceptual framework, it just takes a lot of time to get everybody's ideas together and for us to agree. But I show you this in terms of, a few things to point out. And one is that, all of health, on the left there, you see that there are external forces that drive the health outcomes. And so as long as we continue to remember that there's these structures in place. But I really, in terms of this talk, wanted to point out the middle space here, the community centeredness and engagement, which when I reflect on my education and training, there was not a single day in my research training broadly as a fellow. I had training as a resident. I did a master's in clinical investigation. There was not a single day that I had any lecture or presentation on engagement. And so that's changing. So, currently, at least right now, many programs are starting to embed engagement into the work. But the idea that we as scientists have all the knowledge is part of the problem with why our outcomes, our results, our strategies don't actually improve health for everybody, because we've been under this assumption somehow that we have all the knowledge. So again, to that, the importance of engaging communities, this concept that there's no substitute for the lived experience. And so you as a person living in a community or with a condition, 24 hours a day, you're that person. And so the amount of education and training that an individual can get about diabetes is limited. You may be an expert in diabetes treatment or research, but if you've not lived with diabetes, if you've not had to alter your diet, if you've not if you've not given yourself injections, insulin injections, then you don't know what that's like. And so having that experience and expertise is something different. And so presuming that we somehow with our book knowledge is that we can go into communities or we can create treatments and solutions or preventative strategies without this knowledge is a fallacy. And this also reminds me, when we talk about why engage communities and back to trust and trustworthiness, that, a few different community members have said this is, when we say, why aren't you more educated about the research, or we're sort of trying to push these things off, and they're like, no, we are educated, which is why we don't trust you. And so part of that as well is the, engaging to demonstrate that trustworthiness is critical in these different spaces. So we engage communities in research, improve the relevance of the work, to increase the likelihood that it gets adopted if there are, positive findings, or if we need to de-implement things, strengthens the broad applicability of the work, and decreases disparities and inequities. The last one here, I have Bill's knowledge gaps on the research team. I want to put a pin in this one because it's actually something, it's not written about in any of these publications, but it's something that I've struggled with over the years as I've learned community engagement and the importance of it and how to do it, is that often when we're talking about community engagement, we're talking about marginalized and minoritized communities. And those are the people that we think we need to engage. But also a lot of times we're seeking that because we don't have that reflected on our research team. And so I think it's important to recognize that community engagement should not be a substitute for having a team that has different experiences, who have different lived experiences, different backgrounds, and understands the work differently. They are two different things. They serve different purposes, and community engagement should not be that substitute. And I see this again a lot, and when we're talking about things like social drivers, social determinants of health, they're like, oh, let's just get the community. Like, no, you need a social scientist on your team. Like, you need a conceptual framework with that's focused on that. You should not just presume that community is going to come in and fix the flawed science there. I see heads shaking. You all already know all this. Yes, I should skip ahead. Okay, just let me know. Just wave a flag or something. So what is engagement? Again, many of you know these definitions. Engagement, I think key pieces of engagement is bi-directional. A lot of people programs that have engagement in their title and they're just unidirectional, they're just going out, educating, sending information out. If you don't have a way to get information back in and do something with it, not engagement, not engagement. I have a different definition for community engagement, and this is coming from some of the recent work, which emphasizes that community engagement should have a higher threshold for what's important to the community, and that is focused on these enduring relationships that don't just go away after the research is done. And if you've not seen the recent publication, I think I have it somewhere here, but I'll stay here for a second. The third edition of the Principles of Community Engagement, they talk about at least 15 different definitions that they reviewed around engagement. So there are lots of definitions for engagement. I emphasize here again, the characteristics that and the qualities that are needed, that trustworthiness, humility, which I find that many of us in our ivory towers don't always have a lot of that humility. I will say, particularly physician scientists. I won't go into the specialties of the physician sciences that might have the least humility, but just in general, this anecdote, and I don't have any, trials on this, but it is something that's really important for us to have. And a little bit of speak here, but I also think it's important to acknowledge that engagement is distinct from recruitment. So if the goal of your engagement is specifically to recruit people, then you're not doing engaged community engagement. If your only purpose is to get the people in the study, it's not engagement. It can be engaged recruitment, which is great. We should all be doing engaged recruitment, but it's not engagement. If nothing changed in terms of how you did the work, we don't count it. We don't count it as engaged. Again, not a bad thing, but it's not the same thing. And so don't confuse your outreach with engagement, and don't confuse your recruitment with engagement. This is the Principles of Community Engagement that I mentioned. It was just recently published, one of those documents that was removed from the CDC website early on. And my good friend Liz Cohn, who's the primary editor, had to scramble and find different websites to repost the document there. But this third edition, the CTSA programs had a lot of input in it. So if you are prevention research or other programs that might have been doing community engagement a lot longer than the CTSAs, then you might not find this as useful perhaps as some of us who are in other spaces. And so I think some important things that they talked about in this new edition include the ethics of community engagement, which again, I think obviously for this group is very relevant, but more thought into how we're doing engagement, including around financial responsibilities, fiduciary responsibilities, and ensuring that community organizations are appropriately compensated and recognized for their work. And I'll share quickly that one of the things that I would say we've seen in our teams is that we know how to do engagement. Am I hearing something? Is that me? Am I making a noise? No, okay. As long as it's not me. As we're doing the work, we can write the grants, we can envision the engagement, we can find the amazing people to do the engagement, and then we get into our academic enterprises and the accounting and finance and sponsored projects. People want like a complicated contract signed with the community organization, or they want the detailed billing, or they want the community to like do the work up front, small community organizations, do the work up front and then get reimbursed 90 days later. And so, some of those issues around the ethics of doing the work are challenging, but are, problems that the institutions themselves own. And so we've been able to work through some things to make that better, but there's a lot in terms of, how we treat small, especially small community organizations in this space that needs improvement. Also in this new book, we, some of our work helped to shape this focus on trust and trustworthiness again with Derek and some of our work around trust and trustworthiness, and again, changing that narrative that's highlighted. Some of you may have seen this graphic that we created some time ago. It was published in 2018, but we probably created it 2014, 2015, that gives you a sense of the different strategies. So I talked about all the different ways that you can do engagement, and these are just some of them. So what you're looking at here is along the bottom, the number of stakeholders. So more people involved and engaged, and then vertically going up here, you can see the extent of the engagement. So the questions that I get asked the most about this graphic are, one, again, what's the best way to do engagement? And my answer is all of them. And so we actually have a few projects where we have individuals engaged at every level. So we have somebody who's co-leading, they're on the team, and, with office in my office, community advisory boards, and they're, community engagement studios, so one time, more intense input, and then these single users there. So there are many ways that you can do engagement. The ones that are below the line, so those are short-term limited, again, really not ideal if that's the only thing you're doing. They can help with help the project, but if that's the only things that you're doing, you probably need to strengthen it if you want it to qualify as real engagement. The community advisory boards are something that we see, and we talked about this a little bit also this morning. A lot of projects want to have community advisory board. Everybody's just like community advisory board, and then they don't do any advising, or if they do advising, you don't take the advice, or you don't do anything with the advice. And so it's often that these are really, check boxes for people to say they did engagement. So I would apply that same principle. If nothing changed, you didn't do community engagement. Ideally, your community advisory boards are led by members of the community. People are compensated. They can set the agenda. They can ask questions. They can hold you, they can have the expectation to hold you accountable for something in the process. And one of my my close colleagues, Paul Harris, who many of you may know him because he created REDCap. So he is a informatician and very different backgrounds. We've been working together now for quite some time. We co-lead the Recruitment Innovation Center. So somehow there was decided we need an informatics person and a community engagement person to come together and figure out recruitment. So we've been doing it for a while, and I have fun putting Paul in uncomfortable situations. Like with our community advisory board. So our Recruitment Innovation Center has this national community advisory board, and they're very engaged and outspoken people from across the country. And, the first, early on in the process, I tell Paul, who's not been doing community engagement in his informatics work, and I say, Paul, if you're not uncomfortable in this meeting, we're not doing it right. And he's like, what? It has to be uncomfortable. Yes, you have to be uncomfortable. Like if we're not getting input from them that makes us feel like we should be challenging or rethinking things, then we're not doing something right. We haven't made the environment open and one that they feel like they're giving us critical input, because we can't be doing it right, because again, we've not been successful with improving everybody's health and having outcomes. So in our CAB, we have expectations, again, that if they tell us something, we report back to them what we did with it. And if we weren't able to do something that they recommended, then we tell them why and how we're going to do it later. So a couple of examples I have. So one is the National Precision Medicine Initiative, which is called the All of Us Research Program. Many of you are probably familiar with it. The expectation that they're going to enroll 1 million or more people in this program and this platform. And I have had the pleasure of being the engagement core director, because the program early on said that they wanted to have participants as partners in the program. And this is one of those, I didn't believe them. I was like, they don't know what they're talking about. They don't know what engagement really is. They don't know, like, engaging people in a project that's this large, with this many people, like, it doesn't really happen. Like, that's the kind of engagement that happens in a, you know, an R01 or a small project that, or foundation focused projects that's working with the community. Like, what they said was partners. I didn't believe that they knew what they were talking about, or that they understood what it would take. But nevertheless, I took it as a challenge. We'll come up with some things and we'll see what they will agree to. And so these are, you know, what we proposed and what we have been doing. I should point out, so Liz Cohen, I mentioned, is next to me. She's the person who was the primary editor of that community foundation, the principles of community engagement, and Melody Goodman, who is on the faculty at NYU, has created tools to measure, assess engagement. And so had the pleasure of working with them. Other people on our respective teams. And then in the lower left corner are two individuals who are participants in the All of Us research program, who we eventually brought onto our team after they had completed some of their work in the other areas. And so these were people who, again, attend the meetings and provide input, et cetera. You know, we're going to engage people, integrate, we're going to measure it, and we're going to advance science, lofty goals. What does that look like? So again, bringing in this sort of framework, we're not just talking about, again, engagement at a large scale, but also engagement, precision medicine, genomics, people exploited, eugenics, all sorts of ethical issues, you know, in the background here. And so, you know, thinking about what that looks like to do it well, there's a paper here, in case this is looking as grainy for you as it is for me, that talks about, you know, how we would adapt that approach to this large scale project. But this work actually happened before the All of Us program launched. So in the spring, summer of 2016, we went around the country doing community engagement studios. I know some of you are familiar with them. They're happening here, where there's one-time structured sessions, not focus groups. The intent is to get input that's going to change your research. Community is treated as an expert. They're compensated for that. And I think we might be over 20 now institutions who have some form version of a community engagement studio that they're doing at their institutions. But I had this idea, and again, this is when I don't believe people. And for those of you who've done community engagement and you're doing work that you're used to people like trying to make you do less of it or convince you that, you know, it's too much. So I started with this list of 16 different groups that we needed to engage in to build the program. And I fully expected that someone was going to tell me I could only do 10 or 5 of these. And that didn't happen. So we went around the country doing this. And so this is a group of people who are intended to focus on diversity. So, you know, people who are representing groups that are underrepresented in research, And then inclusivity, so people who are going to have potentially substantial barriers to participating. And that includes people who have hearing impairment, visual impairment, uh, challenges with ambulation or their limited upper extremity function. So, this was the list that I put together. And this is what operationalized that looks like. So we're again around the country, doing these studios in church basements on the south side of Chicago. I mentioned South Dakota earlier today as well. We were in South Florida after the shooting at an LGBTQ nightclub. And so we were really out in the community getting advice from people. I know it looks like a lot of flyover people were missed. The NIH decided where we could go. And they also wouldn't let us go to Hawaii. So it's like, we can't go to Wyoming and we also can't go to Hawaii. But we did this 77 studios, again, in a very short period of time. About 10% of these are sexual and gender minorities. And these are community people, partners that we involved in that. What we did was we didn't send out flyers and say, hey, Vanderbilt and Meharry, come to town, come, talk to us. We contacted community organizations and we said, this is what we're trying to do. Would you be willing to host a meeting for us? We're going to pay you for your time. We're going to pay you to recruit individuals. We're going to pay them for attending. We're going to order the food that you would usually serve. If you were hosting it, that meant you had to get on planes with cash sometimes, because there were a couple of places that we went that the places they usually bought food only took cash. So I didn't tell anybody ahead of time that we were doing that. Like we're boarding the plane with gift cards and cash. This is how you do community engagement. You just can't tell people all the time. You tell them later after it's successful. So this is what the All of Us research program looks like now. So almost 850,000 people have enrolled. You can see here. This is this is the demographics, racial and ethnic demographics from April 2021. So at that time, they had almost half of people were white. So the program had these broad, lofty goals that it was really going to try and reflect the diversity of the country. The demographics have changed a little bit since then. So in the last 4 years, so this is a snapshot just in the last couple of days at the 850. So we're now a higher percentage of those people are white. And, we did have some impact from more recent changes in funding, including decreasing in funding those community organizations and some of the community health programs. So just wanted to give you a snapshot of that. But, to the to your left, these are all the different ways that we have participants involved in the program. So we have participants who were side by side with researchers, NIH leaders on the executive and the steering committees. And so our teams had to prepare them to be able to engage in these, and lots of unseen labor for the people who are doing the engagement to make sure that they had what they needed. These are some of the ways that they have participated. So that before work that set up the help set the infrastructure, really, we said, community says we need more than just digital, can't have all this recruitment happening digitally. They need to have some payment upfront. They need strategies to reinforce that that the program is trustworthy, data privacy, lots of comments related to that. And so we have been tracking that, and again, thinking about how we continue to evaluate that. I want to make sure I leave some time for questions, so I'm going to speed through these, but again, just giving you a sense of how we have been tracking the work and evaluating it. The engagement core was terminated. our award for that was terminated on March 21st. We had a letter saying that the award was terminated. The NIH program officials were not aware that it was being terminated. So the letter came to our OSP, then to me, and then I sent it to the leaders of the program, and they had no idea that it was terminated. So we may or may not be back with continuing this, but the program says it's committed to continuing engagement. NIH Compass, many of you are probably also familiar with this, a newer program. A year ago, I gave a presentation and said that I did not think that in my lifetime career, that the NIH would be giving grants directly to community organizations. And that's what the NIH Compass did. And that program was also recently terminated. I'm gonna tell you about it anyway. So the NIH decided, they finally bought into this, that, okay, if we really want to improve health equity, then we need to engage communities and we need to make it easier, and giving them the money directly is probably a good strategy. And so they announced the Compass Award and they said, we're going to do this. And they had so many people, community organizations interested, like almost broke the webinar server. Like there were so many people interested. And then they had all of these applications and they were only going to fund a handful, and then they weren't sure what to do with it. And so I had the pleasure of getting a call from someone in the NIH director's office, and they said, we need help. We don't know what to do with how we support all of these community organizations, and can you help us? And I said, no, I don't have time. And they said, that's not the right answer. So, so we put together an application for the request for a supplement, and the supplement focused on, trying to identify these resources and tools to really support community organizations. And also they were concerned that they didn't get enough applications from some groups that are really, have been marginalized or didn't believe that they should even be interested. And so we did that work, which included a lot. And by the way, I mentioned this to a couple of people today already. Most of this work, I just have a grand vision about it. And then there are many more amazing, talented people who get to do the work. And so like, oh, we'll just do a literature scan or review and a portfolio analysis to try and understand all of this. And then I'm not the one who's reading, going through 18,000 papers. Like, they're, again, really, really talented information scientists who are doing that work and going through it. And we had proposed that we would have back-end access to the NIH portfolio to do some analysis. We almost got it, and then no, so we did an analysis of what's in NIH report. But I wanted to show you like how we try to stay true to community engagement. So even in this process, we said we're going to have community members who are going to help us with this process. And so we had community members who participated in the again, the design of the literature systematic review, as well as the portfolio analysis. And so they gave input, including the words, the search terms, and how we were thinking about it. And it's really always interesting to me to talk to my colleagues and teams after they do community engagement, especially if they're not used to doing it. And so some of the information scientists, they had really strong reactions to what they didn't know. And I think that kind of experience is what will help people do it differently moving forward. So, one example is that they said, they said, we're going to use an anti-racist, literature review. That's what they were calling it. And the community was like, what's anti-racist about it? And they were like, well, we're gonna use these words and like that, where's your definition? And they really challenged them in different ways. And so I think that's always great. We had some key informant interviews that we're still, in the process of analyzing. So the Compass Awards are terminated. So I'm funding this work now with my new endowed chair, work to try and make sure that it gets done. But, you know, a lot of what we're seeing so far is, again, this focus on power structures and dissemination, and also the relevance of the work, and making sure that the communities have something left. Um, Again, strategy for me is, I never think there's too many people that we can get input from. Like, I think we have to do it broadly. And so as part of that process, we had convenings for the NIH. This was one of the things that they were most impressed by, that we could actually get a community, leaders and tribal communities to allow the NIH to come visit them. And we had an in-person session in Montana with tribal communities, and really got to see again some of the work that they're doing and some of the unique challenges they had in terms of that, capturing those voices of people who are usually marginalized. Okay, so these are the community members, again, are across the country. So again, when I say community, I'm not talking about just in Nashville. So we try to make sure we're doing that work. And again, more examples of the ways that they involved. We were hoping to also involve them in the analysis, the qualitative analysis. And we have one person who might end up doing that. And then I'll just finish with a couple of things in terms of the trust and trustworthiness. You know, important to recognize that trust there are many factors that influence trust and whether or not you're deemed to be trustworthy. And we talk a lot about trust in research, but we don't actually measure it often. And so Derek and I, when he was at Vanderbilt, had many conversations about this and looked at trust in different ways. And this is a project that we worked on in terms of, you know, getting input about what trust means and how it might look different in different populations. And so this is some of the work that we did with focus groups, and looking at, again, their trust and distrust are not the same spectrum. So what increases, decreases trust? Trust is one spectrum, distrust is a different spectrum. Trustworthiness is also very different. And so you can see that, you know, some of the themes that showed up in these different groups will, you know, vary. One of the things that we probably talked the most about is in this lower left box here, when we, you know, talk about what is trust, and that's, you know, the difference between privacy and secrecy. And, you know, we were hearing this from people in the community, and what we're often talking about in academia and health is privacy, keeping things private. And this concept of secrecy being that people don't believe that we have their best intentions in mind, and that we're going to intentionally keep things from them, which is different from what we're talking. Oh, you know, we have all these privacy, you know, statements. We're going to, you know, keep your information private. We're going to do, but they don't even believe that we are going to stay true to the basics of doing what we say we're going to do. And so this idea that we're talking about, the secrecy, and it's so important that we recognize that they have very valid reasons to believe that we're not trustworthy, that we're going to exploit them, that we're keeping secrets, that we're potentially harming them. And so so that's been, you know, really interesting to unpack, and, you know, recognizing in this historical abuse. And the other thing I'll point out from the standpoint of ethics is, you know, the idea of community benefit. So a lot of things that we talk about with the IRBs, and oh, we say the IRB is protecting you, like, and the IRBs are intended to, we say, protect the individuals, but they're not intended to protect communities. Some would argue they're intended to protect institutions and researchers, but even in that setting, you know, what is potentially harmful to communities in terms of research, like with genetics and genomics, is not often considered. And so that is something that came out here. And again, just noting here, we focused on Black, African-American, Hispanic, Latinx communities, and, you know, trust is different in these. So some things in the scale that we validated were consistent across the group, but we're talking about people, African-Americans, people who are descendants of enslaved Africans. Like the community, history of community abuse, exploitation is different from people who might be newer immigrants, newer Americans. There's also different from indigenous people. So the experiences, that group experiences that people have, even if they didn't have those individual themselves, are important in how they perceive and what constitutes or impacts trust there. That's it.
We have plenty of time for questions.
Thank you, Consuelo. That was so impressive and important work. Earlier, we were talking about the importance of clear, dependable communication, about the importance of this type of work. And you led off with it's not truly your mission statement, but I interpret it as a mission statement of improving science and health. And improving science is somewhat of a subjective claim. And I'm going to play devil's advocate a little bit here to promote the goal of good communication. So as you unfortunately know well, the grant terminations along this line are often including statements that research of this type is often of low scientific quality, right? And so that reflects a different claim. And so how do we bridge that divide? Argue that people in this room and all across our campus, people on your campus, have a bit more expertise in what qualifies as high quality science, but of course it's not like a batting average. We can't really measure it objectively. So how do you address that?
Yeah, no, thanks for the question. I mean, I think in terms of, what is good science? What is rigor? What is reproducible? What is relevant? And, the checklists for those could be improved for how we determine what is rigor. Good example would be something we were talking about earlier, which is, if you're studying breast cancer and your scientific study does not reflect the people who have the burden of the disease, then is that good science? I would argue no. But so much of the science, so much of the discoveries that have been done only include, people of European descent, people who are affluent. And we should be, I think right now we should be going through and rejecting and critically appraising work that has been published and understood to be sort of the gold standards to show why it's not good science and why we haven't applied sort of criteria around rigor and reproducibility that we should all expect from good science. I think in general, the way that we're communicating about, what qualifies, what is, low scientific value, based on whose definition, what are the as scientists, like, what are the objective criteria we're using to say that this is true, as opposed to just accepting it as, someone's statement. You can say it's not your priority. We can't argue with that, but to say that it's low value needs to have some criteria, because how can we evaluate all the other research to determine that it was high value?
Well, thank you for a wonderful talk. I'm thinking about your concept of trustworthiness and thinking that it's sort of a multi-level thing, right? People or communities might trust you as an individual. They might trust your team. They might trust the institution that you come from. If it's an NIH-funded study, they might trust the NIH or not. They might perceive each of those things as trustworthy or not. You wear multiple hats, right? You're an investigator. You interact with people as a scientist. You're also vice dean or senior vice dean. And so you have some, like you wear a hat of institutional trustworthiness for your institution. How do you think about trustworthiness at that institutional level? Because chances are people aren't going to trust the research team. They have concerns about the institution that the team is coming from.
Yeah, and right now, I think broadly, we have very little trustworthy, we're very worthy of very little trust. With how we're behaving right now with, changing language, abandoning people, not defending science. And so, this is especially challenging being in roles like this, where we have to go out and face the community and say, I mean, what do I say? What do I say? I don't blame you if you don't deem us to be trustworthy. I think, you know, the actions and accountability of organizations, it's an ongoing process. I mean, we have to continue to show why we are worthy of people's trust. And I think over the last number of years, we've done a lot to do that. I mean, we had a comprehensive, at Vanderbilt, we had a comprehensive racial equity plan. We had new roles and programs where community members were actually coming in to the organization and taking seats and feeling comfortable giving us input. And I think we're gonna have to start over with with a lot of that. And I think with a lot of programs, we're gonna have to do that. And you know, right now, I think the best way that we can do that is to try and understand what the communities, because, you know, we're all around the country talking about loss of funding and worried about, you know, decreases in Medicare reimbursement and how this is impacting us. And there are people who are afraid to go to school or send their children to school. They're worried about, you know, their community organizations don't have resources and funds. You know, they're, again, worried about getting deported. They're under attack. They are scared that they might get, you know, jailed for using pronouns, or if they go into the wrong bathroom. Like, people are afraid, and if we're really partners and to be trusted, we should be supporting them in the ways that they're currently experiencing life, and focus less on how these things are impacting us.
Time for one more.
Yeah, I liked the slide you had with different engagement mechanisms, and I think on the x-axis you had I don't remember if it was the X or the Y, but when it was sort of larger number of people as you went along the axis, you got like co-PI at the top and you got survey at the bottom. And I think you said that when people ask you, you recommend that they do engagement at all these levels. But then I'm wondering what your advice is when the input that you get at those different levels potentially conflicts with the input you might get at another level, right? What you hear from a survey might be different than what you hear at a focus group. So like, how do you recommend that people try to reconcile that when they might be getting, you know, the community's constituted in all these different ways at these different levels? How do you align that when they don't necessarily agree?
I say you should expect that they will conflict. Because again, that's my, you know, pushing colleagues in the space, like, be uncomfortable. You know, we're very, you know, people are different. We're not, you know, cells and test tubes, and you're going to get lots of different opinions and viewpoints. And so that's why in these, you know, brought in the lower levels, and I mean lower like less important, but when you're engaging more people, you should expect certainly there to be some differences and different views there. But the above the line is when you get the input and more of the prioritization and talking through. So if you get different viewpoints from the survey or community engagement studios, that when you're talking with your CAB or the community members on the research team, you're having those conversations about, well, you know, how should we interpret this? Or should we do something different? What should be our next steps? What should we expect? And kind of working through that with people who can take a little more time and evaluate and assist, which is also why I am typically telling people not to have their CAB members in these other groups. Like there are some people who will, and not to say that this is necessarily wrong, but if you have a cab and they're essentially serving as your community engagement studio people, then who's helping you understand and process and make decisions there? So I think about the people above the line as more the decision makers and helping to decision, and this is more data.
Okay. All right. Thanks so much, Dr. Wilson.